Hello everyone. So our today's topic is vasculitis. As we have four categories in the vasculitis. First one is large vessel, second is medium vessel, third is small vessel, and the fourth is variable vessel vasculitis. In the large vessel vasculitis, we have giant cell arteritis and the Takayasu arteritis. Giant cell arteritis is also known as the temporal arteritis and the Takayasu is also known as the aorto arteritis. As we all know that we all give GTs, so it is a large test, that is the grand test. So we can remember it by mnemonic. GT comes in the large vessel vasculitis. So we'll be discussing it one by one. The first one is large vessel vasculitis. In the giant cell arteritis, the patient that we usually see is more than 50 years of age. And in the Takayasu arteritis, the patient that we see is usually less than 50 years of age. And the most common artery that is involved in the giant cell is superficial temporal artery, and most common artery that is involved in Takayasu is subclavian artery. So that is why their other name superficial temporal artery, that is why the other name is temporal arteritis, and there is subclavian artery and the other name is aorto arteritis. And the gold standard investigation that we do in giant cell is a biopsy, in which we see the giant cells and the granuloma. And the most common symptom that the patient comes to the OPD is headache. And most specific one is the jaw claudication. But the most dangerous symptom is loss of vision. I think this is the probable new question that could come. That is the most dangerous symptom is loss of vision. And the gross finding that we see in the giant cell arteritis is the nodular thickening on examination. And there is a special stain, that is the VVG stain. In this, we can see the fragmentation of the internal elastic lamina, as you can see in this slide. In Takayasu arteritis, there is a BP difference present between the upper limbs. And as we know, the most common artery is the subclavian artery. So it can get narrowed and the upper limb pulse become weaker and weaker. Okay, so major difference between the two is, first one is the age difference, and the second one is the artery that is involved. Okay, so our large vessel vasculitis is sorted. So now moving on to medium vessel vasculitis. It includes PAN, Kawasaki disease and the Berger's disease. We can remember it by mnemonic patho ki book. As we all know that patho is a medium sized subject, so we can remember it by patho ki book. So now we'll be discussing it one by one. The first one is the Berger's disease, or it is also known as a thromboangiitis obliterans. And there is also other name, that is the Berger disease, in which E is coming, it is the IgA nephropathy, and in which U is coming. U is like very close to V, so that is vasculitis. Berger's U wala is vasculitis and the E wala is IgA nephropathy. Now the patient is coming with a complaint of severe limb pain, and he's a smoker and his age is less than 35 years. And the most common artery that is involved in this case is the radial artery and the tibial artery. This is like the typical history of the patient. Smoker patient, severe limb pain and less than 35 years age. In the biopsy of this Berger's disease, we will see the neutrophilic microabscesses. And it involves all three of them, like artery, vein and nerve. And the buzzword is like lymphatics are never involved. And initially the patient will have the intermittent claudication, but as the disease progresses it can convert into the pain at rest. And on the DSA we can see the corkscrew collaterals. So this sums up our Berger's disease. Now we'll be coming to the PAN, polyarteritis nodosa. Now the first most important thing is that the pulmonary artery is not involved. PAN, pulmonary artery is not involved. And its associations, like hepatitis B is involved in the 30% cases. Plus it has hypertension due to the renal vessel involvement, because the most common vessel that is involved is renal vessel. But the most important thing is that there is no glomerular nephritis that is seen, despite of renal vessel is involved. That is the most common vessel. And the third thing is abdominal pain or the bloody stools can also be seen. And we can also see the myalgia in some patients. And there is a segmental transmural fibrinoid necrosis, as you all can see. And I think statement in some question that the lesion of different age can coexist in PAN. Okay, so our pan is sorted. Okay, now the third one is Kawasaki disease. In Kawasaki disease, there is a child that is coming whose age is like less than 5 years or something, and the history is like typical history, like he has a fever and the symptoms like cream. So what is cream? Cream is conjunctivitis, but the conjunctivitis is not non-purulent. He has rash, edema, lymphadenopathy, that is unilateral cervical, and the mucosal involvement. And the antibodies that we see in this patient is the anti-endothelial antibody, and it is a very important, it could be a new question, anti-endothelial antibodies. And then on the blood test, we will see that the platelets are high. And the most common complication of this is the myocarditis. And if you ever see a case of pediatric MI, that is so it is most probably the Kawasaki disease. And the most specific complication is coronary artery aneurysm. So what is the treatment that we give in this case is the IVIG plus aspirin. Aspirin can cause the Ray's syndrome, and the first line, if in a question is mentioned what is the first line, first line is always IVIG. So this sums up our medium vessel vasculitis. Now we'll be coming to the small vessel vasculitis, and it is divided into ANCA mediated and our HSP. In ANCA mediated, we have two categories, that is CNCA and the PNCA. CNCA is also known as the PR3NCA, and the PNCA is also known as the MPONCA. Okay. In CNCA, we have vaginous granulomatosis or the granulomatous polyangiitis. But in the PNCA, the major one is PCM. PCM. तो C से है हमारा Churg-Strauss syndrome and M से है microscopic polyangiitis. In the Churg-Strauss syndrome, we'll see like C is like E. So it is eosinophilic granuloma is also seen in this. But in microscopic polyangiitis, granuloma is absent. And we will see the leukocytoclastic vasculitis. As we can see that vaginous is mostly involved in the CNCA, but it can also be seen in the PNCA. If a statement question came like vaginous can be seen in the PNCA, so it is yes, but mostly it is involved in the CNCA. And this vaginous granulomatosis is also triggered by the infections. And these are some features of vaginous, that is granuloma is seen, and there is a triad that is seen, that is upper respiratory tract, lower respiratory tract, and the kidney is involved. In kidney we have RPGN. In upper respiratory tract infection we have epistaxis, sinusitis or the saddle nose appearance. In lower respiratory tract we have hemoptysis or the cavitation is seen. So this sums up our ANCA mediated vasculitis. Now the second one is HSP, that is Henoch-Schönlein purpura. It is seen in a child and it associated with the IgA, and the platelets in this disease is normal. But as we have already studied that in Kawasaki disease the platelets are elevated. One thing that I also want to add in Kawasaki is that it represents with the strawberry tongue, which is also seen in the scarlet fever, which is caused by the Streptococcus pyogenes. Okay, and in this we can also see pistia lines or the sandpaper rash, if you can remember it. Okay, so coming back, so in HSP the patient can present with the purpura. So we can remember it by mnemonic purpura. Okay, so that is purpura, arthralgia, abdominal pain, and the renal involvement that is present as hematuria most commonly. And then leukocytoclastic vasculitis can also be seen in the HSP. Okay, now we'll be coming to our last topic, that is variable vessel vasculitis. So in variable vessel vasculitis we have Behçet's disease, and there are various features of this. The first one is painful oral ulcers, and the most important thing is it is non-scarring. That is only thing that is non-scarring, painful oral ulcers. And the second one is painful genital ulcer, that is scarring. And we have arthritis, and we have bilateral panuveitis, that is also scarring in this. And in pediatric patients we can also see pulmonary aneurysm. And the antibody that is involved in this disease is alpha enolase. And we have also, you know, that it is HLA-B51 associated disease, and on biopsy we can see the neutrophilic vasculitis. And there is a pathology test, one little test that is involved in this disease also. So our Behçet's disease is completed. So now this is the tiny things, like the most common vasculitis which is seen in the adult is giant cell arteritis, and in children is HSP, which is in the world, and and Kawasaki in the Asian population. Okay, these two conditions, as we know, is seen both in children's, like Kawasaki is also in kids and HSP is also in the children's. Okay, so HSP is in the world and the Kawasaki is in Asian population. And the second thing is like granuloma. We have studied granuloma in many places, and the granuloma is seen in four conditions, that is in giant cell arteritis, in Takayasu arteritis, GT, okay, and the Wegener's and the Churg straws. Okay, these are the four conditions in which granuloma is seen. And here we come to the end of this video. So I hope you like this video. If you found this video helpful, so please like, share and subscribe.